My name is Stephen Teach, and I run Impact DC, which stands for Improving Pediatric Asthma Care in the District of Columbia. I'm also recently the new Division Chief of Allergy and Immunology, which is kind of odd because I'm a pediatric emergency medicine doc. So what's about that? Well, I have credentials on the research side. You know, my research portfolio really is in inner city asthma principally, but really at its core is interested in why children, particularly inner city children, but children in general, are increasingly so darn sensitive to their environment from the point of view of asthma and other atopic diseases, and what we can do about that. So that's kind of why, and so Dr. Max Kopis asked me to do this, and I do it with some humility, and I ask people to think of me kind of like a PhD running the division. But there's a bunch of young allergists and immunologists, and we're growing, and we're very eager to see your kids. And if you have any access issues, Teach at Children's National. Okay, just let me know. I'd be happy to help you. So I'm here today to talk about lessons learned from the difficult to control patient, and this will be a mixture of evidence-based medicine and sort of anecdote. What we've learned through our program seems to work best for kids, and I'll try to tell you when it's got a strong evidence base and when we're kind of out in the range of anecdote as we go along. I'm going to really do three things, though. I got the podium. I'm up here. I'm the last to go. I'm going to talk a little bit about Impact DC because I always do that when I talk. And then I'm going to talk a little bit about the asthma epidemic, okay? And I'm going to grade our response to that epidemic as a cumulative pediatric group of professionals. My focus is going to be on disparities in care and outcome, looking at disadvantaged, principally urban minority kids, but not entirely. And then we'll segue quickly to the lessons learned. And I have four. I got 4 lessons, and this is kind of sort of for fun, kind of at the end of the day. You guys have had a long day. Number 1, the NIH Guidelines. They really work. Okay? They really, really work. Rich kids, poor kids, black kids, white kids, urban kids, suburban kids, rural kids. You use the guidelines, your patients get better. It's been shown over and over and over again. What works best? Technique. It really matters. Okay? Handing somebody a spacer and say, go home and use this 2 puffs BID. Okay? Asthma is about devices. Okay? It's about properly instructing your patients in the use of devices. This isn't swallowing a PPI. Okay? This is really, this is much more about technique. And this is where the devil's in the details. Technique, it really matters. Adherence, it really matters. Okay, this is by far and away the most common chronic disease of childhood. Chronic diseases are managed with longitudinal, consistent care. We as pediatricians are great. You got pneumonia, antibiotics, you get better. Ear infections, you get better. Okay, bone broke, we fix. We are experts in episodic disease. We are, as a community, not especially well trained to take care of chronic disease. And chronic disease includes really careful attention to adherence, and we'll talk a little bit about motivational interviewing. Finally, in terms of the environment, these kids are saturated with exposures to which they are sensitive. I have given up long ago, particularly in our disadvantaged urban population, but I would say also for all of your kids, don't ask for the world. You can't change every aspect of a child's environment. Take the bedroom, okay? Take the bedroom where the kids sleep, and we'll talk about the safe sleep zone and some principles about that. Okay, first, Impact DC. We were founded in 2001, originally with funding from the Robert Wood Johnson Foundation. We're going to be celebrating our 10th anniversary next fall. Our focus throughout our existence has been on urban kids with high recidivism for the emergency department for asthma. That is the kids who come in over and over and over again. Okay, now you've probably got kids who aren't using the ED a lot in your practices, but who get flare-ups over and over and over again. So think about those kids. We've evolved into a highly collaborative program of clinical care, advocacy and outreach, surveillance, which underlies a lot of what we do, and then what's called clinical and translational research. And I can talk to you another time about our program in that, but we go all the way from T1, which is bench to bedside, to T4, which is really policy and community-based stuff. Okay, so the full spectrum of clinical and translational research. Our mission statement is nothing less than to improve the care and outcomes of disadvantaged urban and largely minority children and adolescents with asthma in the DC metro region while serving as a model program for the nation. We're not known for our humility. And here's the program laid out. I'm particularly, I don't know, is this working? I can't really tell. Particularly like this box here, because in that box, those of you who know children will recognize pulmonologists, you'll see allergists, you'll see general pediatricians, you'll see hardcore researchers, molecular researchers, you'll see hospitalists, you'll see nurse practitioners, and you'll see docs. We truly are a multidisciplinary, highly collaborative program that really is beginning to be really one of the critically important parts of children's response to the asthma epidemic. And again, we've got programs in care, advocacy, and a whole lot of research, most of which at this point is NIH funded. So with that, though, let's just review the asthma epidemic in brief. There are 6 million children less than 18 years of age with asthma in the United States. Together, they make about 730,000 emergency department visits every year, nearly 196,000 hospital admissions every year, and most telling of all, nearly 15 million, that's million, lost school days per year. So for every emergency department visit that we see at Children's National, on a population basis, there's about 20 missed school days. All right? Asthma has a pervasive, roiling sea of morbidity that our families contend with day out and day in and day out, and affects mom and dad, missed work. And you know what was most evil about this disease is the way it attacks kids in the fall. All right, you guys all know this, middle of September. It's been worked out actually on a nationwide basis, about 13 and a half days after school starts. Okay, it doesn't matter what school district you're in, 13 and a half days, bingo, the September epidemic starts. The viruses are circulating, and kids are spending more time indoors, in indoor allergens, and boom, away it goes. And the problem with that is the kids then, they start coughing and wheezing, they're missing school, they're struggling, they're not concentrating, they fall behind on their homework, and they get set up for a year of school failure. Okay, and this is a process we see in the DC public schools among hundreds and hundreds of kids every year, and it really is something that we pay a lot of attention to. And it's getting worse. Most of you have seen some variant of this slide, the prevalence of the disease really rising dramatically from about 3 or 4% when I was a very young doctor in the early 80s to close to 8 or 9% now. So this we don't have a lot of control over, and why this is happening I could come and talk to you about another time. We do have control over this. These are a simple measure of asthma morbidity in children. These are pediatric ED visits for asthma starting in 1992, okay, and ending in the mid-2000s. And you can see that's a totally flat line, 0 to 17 years of age. Collectively, as a pediatric community, I give us an F. An F. That's the other F word, fail. Okay, we are failing to meet the needs of these children. And it's pretty egregious when you think about it. We have evidence-based guidelines for care and research that improve outcomes in any population they're studied. But as a pediatric community, we have done nothing to budge the emergency department visit rate in this country over the last 2 decades, and it's appalling. Okay, and I hold myself responsible, and really all of us responsible for this. We need to do better by our patients. And it's about disparities, too. Here's just a simple measure, okay, that strikes very close to home, and this will lead into some really cool maps which sort of show the asthma epidemic in greater DC. This is the national ED visit rate from the National Hospital Ambulatory Medical Care Survey, rate per 10,000 for pediatric ED visits in the youngest kids, under 5. This is just one measure. There are lots of these. And they all show the same thing. So the national rate, about 160 visits per 10,000 per year amongst African-American children, okay, about twice that, 380 visits per 10,000 per year. Among the similar residents in Washington, D.C., what do you think the number is? No, just guess. Twice as high, 50% as high. Twice as high, you're close. It's almost 750 visits per 10,000 per year. It's really striking. We are at the center, as a community, as a metro region, of a real epidemic that really disproportionately affects the most vulnerable kids in our community. What's really interesting is that Healthy People, which comes out every 10 years, the CDC document, the target for 2010 was 80 visits per 10,000 per year. We didn't make it. Okay. We didn't come close. Okay. We had a lot of work to do. And it's really, for those of you who know DC, really affects, again, the most vulnerable and disadvantaged. Here's the Potomac River. Okay. Here's the Anacostia River. Here's southeast DC. Here's Northwest DC. Okay? Here's Rock Creek Park. All right? Zip codes in green, okay, that's where the ED visit rate is really low. Now, what do we know about Northwest DC? Home of the lobbyists, the lawyers, okay? Minority population there, only about 12%. Okay? Let's go over to Northeast DC and Southeast DC. Nearly 100% minority. Not as many lobbyists and lawyers live over there. In Southeast DC, the unemployment rate now among African-American males age 18 to 30 exceeds 25%. Okay, poverty is rampant, as you'll see in a second, and you'll see that the visit rates over in those neighborhoods are just off the charts. And again, bear in mind that Malia and Sasha live with their father right here. Okay, in the center of what is arguably the capital of the most powerful and wealthy nation that's ever existed in the history of the world. Okay, and we have ED visit rates which show a greater than tenfold difference in rate within the same metropolitan community. Okay, I really think this is a problem, and it's heavily linked to poverty. Here's a complex measure of poverty from our group at Children's National. These are census tracts, and the red and the orange and the yellow, that's where the poor families live. Okay, and you can see the close correlation between poverty and the high visit rates in the zip codes. Okay, poverty is a potent independent predictor. Anybody know what these three red areas are here? Those are universities, right? That's American University, that's Georgetown, and that's GW. So those are poor students, not poor families, all right? And it's about access, too. Here's a map which I hope speaks to those of you in the audience. This is Metro DC. We published this in Pediatrics in 2006. This is Metro DC. The dark areas, okay, that's where there's a high density of clinicians who care for children. I'm talking nurse practitioners, PAs, pediatricians, family practice docs. Okay, where it's dark, that's where the geospatial density of docs and NPs and PAs is high. So when a mom walks out her door, okay, and she looks around, what's the density of providers in her neighborhood? Okay, literally. And you can see just how low that density is in Southeast, Northeast DC, and here in the Georgia Avenue corridor, and how high it is again in the land of the lawyers and the lobbyists out here. Okay? Go over into PG County again, you see just how low those pockets are. Now what's really telling, let's take the addresses of 500 kids who made visits to our emergency department at the main campus at Children's and drop them on the map on the right, on your right. Okay, here we go. Boom. There they are. Where do they cluster? All right? Not in the land of the lawyers and the lobbyists, but in the land of where the clinicians are few and far between. Okay? Really quite striking and quite telling. So now you're all kind of beat up like, oh my God, we're in a total state of failure here. And we are. We got a lot of work to do. All right? So I thought I'd put together just 4 lessons from our program. Okay? And we'll just go through these kind of quickly. I got 10 minutes and 41 seconds here according to the clock. Lesson number 1, the guidelines work. Okay? They really, really do, and I can think of no better way to prove this to you than to just review a little data from our experience with Impact DC. So here's what happens typically with the emergency department, and again, I kind of feel the elephant originally from the perspective of asthma as an emergency medicine doc, so bear that in mind. But so this is the way it's supposed to work. ED-based follow-up after acute ED visits for asthma. You got a kid out there in the community. He or she has a flare-up, right? They go to the ED. They get discharged, all right? They're supposed to have primary care follow-up, right? And in there, there's supposed to be opportunities for improved care, right? That's the way they tell us it's supposed to work, right? Let's take the world of Dr. Mark Weissman's patients, children's health centers, all of them put together. He takes care of greater than 50%, I think it is, Mark, of the Medicaid-eligible children in Washington, D.C., okay? What percentage of those patients that we see in our emergency department, and I'm picking on Mark because we actually could do this study electronically through the electronic medical record, okay, actually follow up? About 21% within 30 days. Okay, nearly 80% of those children never go back to the primary care provider where you lose the opportunities for improved care. So we offered a different way. We said, hey guys, you love the emergency department so much, come on back. All right? We did this totally out-of-the-box thing. We said, you love us so much, come on back. And we invited these families to actually return for transitional follow-up care visits in the friendly confines of the ED itself. Holy mackerel, is that weird. But you know what? It totally worked. Over 70% of the families that we invited came back. And using a program of that utilized asthma educators in clinical care, we see the kids for 1, 2, maybe 3 visits with the idea that we educate them intensively in technique, adherence, a conceptual model of the disease. We use motivational interviewing to try to improve adherence. And then we return them very deliberately to their primary care. We really are not in the business of taking care of asthma longitudinally. We fundamentally, at our core, believe that the vast majority of children with asthma can be managed in their primary medical care home. Okay? So thus was born the Impact DC Asthma Clinic. We're very hands-on. We use a lot of asthma educators, as you can see, who function very much as peers to the moms and the dads who come in, and we try to make it really a time. But it's a lot of hands-on stuff. Okay? You can't do asthma on the cheap. You can't do it on the quick. All right, and this is one of the challenges that I admit everybody in this room has. But I think if there's one group of patients in your practice who really will respond to an investment of time, it's this group. Okay? And we use the NAAG Guidelines. It's not rocket science, guys. Here they are. They've been released 4 times now, most recently in the spring of 2007. August of 2007. And you can go to the NHLBI website, National Heart, Lung, and Blood Institute website, and download the thin version. Okay, so there's the summary, 80 pages. And then there's the full document, 480 pages. I recommend the 80-page version, okay, because it's got all the highlights in it. And cannot locate the internet server or proxy server. Don't know what that means. There we go. And what are the priorities of the guidelines? Well, they're pretty simple. And if an ED doc can do this, I really know that the rest of you all can do it. Proper diagnosis, patient and family education, identification and control of triggers, a very clear medical plan with a very heavy reliance on inhaled corticosteroids. Okay? You can use a little bit of inhaled corticosteroids every day, or they can visit us in the emergency department a couple times a year and we'll whop their pants off with PO dexamethasone. I mean, we will just whop their pants off. And then effective longitudinal care. Okay, I really have a rule of thumb that no child with asthma should leave a primary care provider's office without the next appointment made for asthma care. Okay, asthma planning visits. Okay, there's never such a thing as, oh well, we'll check in with you next time, whenever that is. No, they leave with an appointment. That's my really one hardcore recommendation to you. So we did all this in our did it work? These are inner city kids, right? Who really were using the ED over and over again, sometimes 3, 4, 5, 6 times a year. We were pouring prednisone and dexamethasone into them over and over and over again. Did it work? It really did. In this very, very difficult to control population, okay, by really sitting down with them, spending the time to do the education, the device teaching, the adherence teaching, the conceptual model building that makes a difference in asthma care, we were able to, way out at 6 months after the start of the intervention, to nearly double the rate at which patients were taking inhaled corticosteroids. Okay, really very, very dramatic, highly statistically significant, and more importantly, very clinically significant. How do I know that? Well, we looked at their ED visits over the following 6 months, which we were able to cut nearly in half. Clinically significant and very statistically significant. And again, we published this in a randomized clinical trial now 5 years ago, really, so it's quite old data. So it works, okay? The guidelines really work, even in the most difficult urban inner city populations. What was the effect on the ED as a whole? Well, the visits dropped dramatically in the district nationwide, and this is one of the untold stories, really, of asthma care in the district, is that ED visits district-wide have dropped about 25% since they peaked in 2008. Now, that was temporally very much correlated with the creation of the Impact DC intervention. So we take some pride in that. But you can't control everything. What happened in 2009? Novel H1N1 epidemic, right? And we saw visits spike again, most dramatically in October, when your offices, I'm sure, were incredibly busy. So you can't control everything. Lesson number 2, technique. It really matters. Here's some data from Sleeth. recently in pediatrics. He did an observational study of about 300 kids aged 8 to 16 from 5 primary care practices in non-urban areas in North Carolina. So hot off the press, okay? 8% of this group performed all the correct steps for use of an MDI and spacer. 8%. 92% had at least one error. The discus, only 22% performed all the correct steps for use of a discus. Really, really quite striking. So what are the simple take-home messages in the use of these devices? Well, let's talk about MDIs and spacers. First, a few comments, and then I'm going to actually pull them out and kind of just pretend you're all moms and dads, okay, and I'm teaching you how to use these things. Get your kids off nebulizers and onto MDIs as soon as you reasonably can. They are better ways to give medicine, okay? Every study supports this. Okay? You deliver medicine more efficaciously with an MDI and spacer than you do with a nebulizer. Okay? But you have to use the proper technique, and that's why families will tell you these things, they don't work. Okay? They don't work because they're not using them correctly. Okay? If they're using them correctly, they work better. MDI should always be used with a spacer. Okay? We do not teach, nor does the evidence support, particularly in young children, this pursed lip technique. Use the spacer. Okay? Spacers need to have a good seal. Okay, if you don't have a good seal and the kid's breathing mostly room air and not in through the spacer, they're not going to work. Okay, so one of the principles of teaching spacer technique, whether you're using a mouthpiece or a mask, is to make sure the seal is really good. Okay, a single deep breath is better than tidal breaths. So no matter which of these you use, if you can teach the single deep breath, it's much, much better than either one of these, which either one also can be used for tidal breaths, but a single deep breath is a better way to give the medication. With these devices, you want to breathe slowly, deeply, and hold it. Okay, so what does that mean? Shake it up, prime it 4 times if it hasn't been used. If it's brand new or it hasn't been used in a couple weeks, shake it real good, put it in there. What I teach is complete emptying. 'If you don't hear the then they didn't do it correctly. Okay? With a seal, and I can actually get a seal on the yellow guy here, what you want to really look for is both valves clipping. And one of the, there's very good evidence now that most of the medicine is actually gotten in the first 2 breaths. So we always teach 5, 6, 7 breaths. It's really the first couple of tidal breaths that get almost all the medicine. Okay? So that really speaks to timing carefully to the inhalation, getting a good seal, getting a good seal, getting a good seal. But as soon as you can with these kids, teach them to blow out. And hold it. Okay? And you can teach even 3- and 4-year-olds to do that with the yellow mask. MDIs and spacers, these require a different technique. Okay? Now, I don't own a single shred of stock in any companies that make asthma medications or devices, okay? So I pull this guy out, you all recognize him, okay? I only use him because he's a dry powdered inhaler. They require a different technique, right? Okay, it's powder. You really got to suck this guy in, right? So down he goes, all right? Six, 7, 8, 9, 10. If you don't hear the then they didn't do it correctly. Okay? It's a full contact sport up here. Lesson number 3, adherence. It matters. Okay, so many of your patients, they're having trouble. You start them on ICS, they use it for a couple of weeks, they get better. I don't need this medicine anymore. All right, they're better because of the medicine, not in spite of it. So how do you really build adherence? Well, really the literature suggests that motivational interviewing is really the best way to do this. Build empathy and verbalize understanding. This really stinks that you have asthma. Tell me, what's the worst part for you about this disease? Identify the goals. I want to cheer, okay? Acknowledge and address the barriers. Well, it must really be terrible if you want to cheer and you can't get up because every time you do a backflip, you turn blue and start wheezing, right? That's a problem. What can we do to think about that? Well, maybe if you start taking your medicine and you tape the inhaler to your toothbrush, you could really remember, and so build self-efficacy towards change. Set goals and then work with a child to understand how they can change. Finally, lesson number 4, because I'm a few minutes over, don't ask for the world, take the bedroom, and this is really the safe sleep zone. Okay? Not a lot of evidence. I really do? Oh, I got more time? Oh, cool. All right. So I'll slow down. The safe sleep zone. In spite of all of our attempts to mitigate the environment, there actually is very little evidence at all that aggressive attempts at home mitigation of the environment make much of a difference. Let me repeat that. Despite all of our attempts to address triggers in the home, to remove carpets, to banish pets, to clean up dust, to control leaky water, that kind of thing, there is very little evidence to suggest that mitigation of the home environment really has an effect in improving asthma outcomes. And it's kind of humbling. It really is. But there have been multiple studies and even very intensive interventions supervised by home environmental professionals who come in on a weekly or monthly basis into inner city homes and suburban homes, had very little effect in this regard. Nonetheless, so I approach it with a little bit of humility, and so should you. You're much more likely, if I could choose one thing, inhaled corticosteroids or cleaning up the bedroom, I'll take the ICS 10 times out of 10, okay, because that's where you're going to get your big effect. Okay, but I think we empower moms and dads to do something about their kids' environment, and it's important to do that. So we take the bedroom. Okay, most kids spend 8 to 10 hours with their head in that pillow every night. All right, so that pillow and that bed and that bedroom. Okay, let's make them as asthma-friendly as possible. Okay, and then begin to move those principles out from the bedroom into the common areas of the home, then the non-common areas of the home, and finally into the school and the daycare. And be humble about it, and just do common sense things, and don't go way overboard here. So what do we recommend? Dust with a damp rag. Nothing fancy. Cleaners, usually have perfumes in them. Perfumes mean particulates in the air. Particulates are irritating to the lungs. Nothing fancy, just a damp rag. No carpets if possible. So if the family owns their own home and they can pull up the carpets all together, just go to hardwood floors or linoleum in the child's bedroom, take out the area rugs, that's ideal to get rid of the dust mites and the molds and the pet dander that reside there. Wash sheets at least weekly and hopefully twice weekly in hot water. I mean blistering hot water to kill the dust mites and get rid of their allergen. Pillow covers, and mattress pads, again, very little literature to suggest these actually make a difference, and they're very expensive, okay? And these are the kind of thing you don't want to buy a cheap one. I have a saying, don't buy a cheap coffee maker, because that's what you get, okay? So don't buy cheap encasings, pillow covers, and mattress pads, because it's exactly what you get. You get a not very effective device. But again, if your families are financially strapped, this isn't the first thing that I'd have them spend their money on. This is important. Don't eat or drink anything in your bedroom. Okay, why? Because the crumbs and the spills attract insects. Okay, and many of our homes, even in very advantaged neighborhoods now, have roaches, what inner city families call water bugs. And they come out at night and they're heavily sensitizing, and exposure can be very difficult to control. But they're only looking for one thing, and that's food and drink. If you don't offer it to them, they'll go away. They won't come at all. Pets simply aren't welcome. Okay, they're really not, because not only do they bring in pet dander, but a host of other allergens as well, from molds to dust. And finally, don't burn anything in the bedroom. We long ago learned that it's one thing to ask if cigarettes are smoked. Anybody smoke in the home? Nope. We don't smoke in the home. Nope. And maybe they don't smoke cigarettes in the home. But if you really start saying, well, do you smoke cigarettes, pipes, joints, blunts, bongs, incense? It's amazing how honest people will become. Oh, yeah, well, I guess we do. We get home from work every day, and my wife and I share a joint. And you do that, do you? But that's not a cigarette, but it's burning in the home. And these are just the real-life things. And if you don't ask, they're not going to tell you. And they're not going to give you the opportunity to counsel them. So be broad in how you think about burning things.